spirogram, how to do a spirometry. Okay? And then we're going to define the lung volumes and the lung capacities, and then try to figure out which ones will be decreased or normal in obstructive disease, and which one will be normal or decreased in restrictive diseases. Okay? So that's why today's lecture is very important, but it's very, very short. Okay? All right, so just working. All right, so pulmonary disease is a major health problem worldwide. Okay? The diseases have escalated in elderly population. There is increased incidence of asthma, for instance, chronic asthma, COPD, which are the chronic bronchitis and emphysema, TB, lung cancer, trauma, and other emerging infectious diseases. So it's everywhere, okay? And if I'm not mistaken, I think pulmonary diseases are like the 5th major cause of death in the United States, okay, especially COPD, okay? Advanced medical techniques are able to save victims who would otherwise survive, okay? Sophisticated methods are needed to objectively measure respiratory functions to better evaluate these subjects. So we have several ways that we can measure, that we can use to measure lung functions in patients that have pulmonary disease. So the lung disease is insidious, meaning that it will sneak in and get you. Sometimes you can go for months and don't even know that you have any kind of lung disease. By the time you realize that you have it, the disease probably would have done some irreversible damages, okay? So you just don't know. It's just like having hypertension, okay? You can move around for years and not even know that you have hypertension. And you go to the doctor one day and they check your blood pressure. And from there you go, you know? Because of the, and that is because the pulmonary system has a great capacity to hide the disease, okay? You have small cancer growing inside your lungs, you probably won't even know it. Your pulmonary function will be normal for a long time, okay? By the time you begin to have symptoms, you know, it's like it's already done some major damages that you cannot reverse, okay? So the pulmonary system can hide diseases. The disease eventually reaches critical point. PFT values decrease rapidly, and by the time abnormalities are detected, some aspects of the disease may be irreversible. So diagnostic tests are devised to evaluate all aspects of the pulmonary system. Then what we can do is that we can measure your airway integrity, okay? And that includes checking the flow rate, okay? How easy it is for flow to come out from your lungs. Because when you have a pulmonary disease, like COPD, the major problem is them getting the air out. Okay, they have easier time breathing in than they have breathing out. So we are mostly concentrating on the expiratory flow. That's how we define obstructive disease, okay? So we can check flow rates, and then we can check resistance. Because if the flow cannot come out from your lungs the way it's supposed to come out, then they will have resistance. There is some kind of resistance in there that is blocking the flow from coming out. Okay? We can measure their respiratory muscle strength. This is by measuring the vital capacity. The vital capacity measures the strength of the respiratory muscle. Okay, if you have a normal vital capacity, it means that you have normal lung function and that you can you can cough effectively to clear your airways of secretions. But if your vital capacity is abnormal, then your respiratory muscles are very weak. Okay, so we can measure that. We can also check on the mechanical properties of the lungs and the thoracic cage. And that is by measuring the lung volumes. We'll measure their tidal volume, we'll measure their inspiratory reserve volume, we'll measure their residual volume, and then we'll measure their lung capacities. We're going to talk about those. We can measure their compliance, lung compliance. Now, if you remember from mechanical ventilation, lung compliance is how easy the lungs can stretch, okay, when ventilated. Okay? So a lung unit that can easily stretch has high compliance, okay? Meaning that you're going to require low pressure to open it up. A lung unit that cannot open up with ease has low lung compliance. Okay, so what we can measure those, for instance, COPD patients have high lung compliance, okay? And patients that have restrictive disease will have low lung compliance. We can measure efficiency of gas exchange. And that means, how well gases can diffuse from the patient's lungs into the blood, okay? Before gas can diffuse into the blood, it has to cross over the alveolar capillary membrane, okay? So that's what we're testing when we do the DLCO, for instance. Okay, so you breathe in, and then here's the blood. Before the oxygen can cross over into the blood, it has to cross the AC membrane, okay? So you may be having a diffusion defect if something is wrong with the AC membrane. For instance, if you have pulmonary edema, that can impair gas diffusion. If you have scar tissues here, that can impair gas diffusion. If you have decreased surface area, like if you have atelectasis, your lung units are this way, that can also reduce gas diffusion into the blood. Okay, so we measure those by a test that we call the DLCO. I know you found out about that. We're going to talk about that down the line. And then we can measure neurological response. Okay? Now, CO2 is what makes us breathe. Okay? So anytime a tank of CO2, for instance, they bring a tank of CO2 and open it up here, okay, your heart rate will start going up because you're going to become hypoxic. The CO2 will attach you to your hemoglobin before the oxygen has the chance to do so. Okay, so what we do in testing the neurological response is we let you breathe in CO2. Okay, if you respond by increased heart rate and hypoxemia, then we know that your central nervous system is working well. Okay, so that can also be tested in the pulmonary lab. Okay. They can do an exercise response. Okay, see how well you are responding to exercise. They can do bronchial provocation test to measure how well your lungs are working. But that test specifically is for patients that we suspect, have asthma. Okay. They will let them breathe in what we call trigger, like histamine. Okay. or methacholine, okay, something that constricts their airway. Okay? And then they see how they respond to it. Okay? When they have less flow coming out from their lungs, then that would mean that they may have asthma. Okay? And then they can also do sleep studies. So, obstructive pattern. The way I look at it is, this is, just take this here to be your trachea, and this is the alveolus. So obstruction is from here up. The air cannot come in, or it cannot go out with ease. That's obstruction. Restriction is down here. Restriction just means that your lungs cannot expand as much. Okay? When you're breathing, instead of your lung units going like this, they will kind of go like that. Okay, so think about it that way. Obstruction is up here, restriction is down here. So for instance, when I say, is atelectasis obstructive or restrictive? Well, atelectasis is down here. So that would be restrictive. When I say, well, how about pulmonary edema? Well, pulmonary edema means you have a lot of fluid in here. That would be restriction. Okay? But now if I say asthma, well, they can't breathe. It's up here. If I say emphysema, it's up here. Okay? They have difficulty getting the air out. That would be an obstruction. And if the lungs cannot expand as much, then you got restriction. Okay? So it says that obstructive patterns are diseases that cause airway flow limitation that are not fully reversible with bronchodilator therapy. And that is true. Okay? You can't cure asthma. You can't cure emphysema. You can't cure bronchiectasis. You can't cure cystic fibrosis. But we can live with all these diseases. Then you can give them bronchodilator to improve their pulmonary function, but we just can't cure it. Okay? We can fully reverse the disease process. Okay? Now, there are only 5 diseases that are obstructive in nature. If you can remember those 5, everything else that you can think of in this world is restrictive. Okay? So these are the 5 obstructive diseases. We remember them by the CBEB. Okay, CBEB. Now the first one there is cystic fibrosis. Now that is an inherited disease that affects the lungs and the pancreas. Patients with cystic fibrosis make a lot of copious amount of thick secretions, very sticky secretions. Okay? And then the secretions will be what is going to cause the obstruction. They have secretions here, so that when they inhale and when to breathe out, the secretions will be in the way of the air coming out. So that's how it causes airway flow limitation. Now, these type of patients always have a lot of pulmonary infections. Okay? There is a drug that works really good for patients that have cystic fibrosis to improve their lung function. Does anyone remember what drug it is? That you can aerosolize to somebody who has cystic fibrosis. You remember Ganesh Alpha? Or sometimes we call it promazine. Okay? So if you get a patient that has cystic fibrosis and needing a mucolytic agent, something that will loosen up their secretions, you are better off giving them the donesa for the pulmosan. Okay? Because what happens is that because they have a lot of pulmonary infections, the white blood cells arrive to the site and fight off the infection, and then after they die, because they fight the infection, then they die. Okay, the debris from the white blood cells is what actually causes their secretions to thicken up. So this medication here really is very good in losing up their secretions. So just remember that donesa for pulmosan is a good mucolytic agent for patients that have cystic fibrosis. Okay? So now we know now that cystic fibrosis is obstructive, and it causes obstruction because of all the secretions those type of patients make that block air from coming out from their lungs. Any questions about that? Now, the next obstructive disease is bronchitis, actually chronic bronchitis. Chronic bronchitis. Okay? How do we make diagnosis of that? When somebody is been coughing for 3 months, okay, consecutively, and producing secretions for 2 months. That's the way we define chronic bronchitis. What causes that is mainly cigarette smoking. Cigarette smoking is what causes chronic bronchitis. And sometimes air pollution. Air pollution can cause that. Okay? So in chronic bronchitis, what happens is that you have infection inside the lungs that causes increase in the number and size of the goblet cells. Now, the goblet cells are the cells that make secretions inside the lungs. Goblet cells make the secretions. So with chronic bronchitis, you have increase in the number and size of the goblet cells. Therefore, you have a lot of secretions, unprecedented amount of secretions inside the airway. So in terms of chronic bronchitis, what causes the airway limitation is also secretions. Secretions blocking the airway. Okay? And then the next one is asthma, chronic asthma. Okay? Now, in chronic asthma, what you get is airway hyperreactivity. Your airway is very, very sensitive to some allergen. It can be if you are exposed to cold air, you have asthma exacerbation. It can be if you are exposed to animal dander, you have triggers. It can be if you get pneumonia, you have airway hyperreactivity. Ragweed, for instance, may cause airway hyperreactivity. So your lungs are very, very sensitive to an allergen. Okay? And because of that, then, you have bronchospasms. So your airways, now initially, if this was the diameter of your airway, when you don't have problem breathing, you don't have any exacerbation, and now you have exacerbation, you're going to have bronchospasms. So the diameter of your airway will decrease like that. And then, as air now is trying to come in when you breathe in or breathe out, you have wheezes. So in essence, one of the things that causes wheezing is reduction in the diameter of the airway. Okay? So in terms of asthma, what causes it? Obstruction then is bronchospasms, decrease in the size of airway lumen. So that's what makes it obstructive. Any questions about that? How can we reverse bronchospasm? If somebody is having bronchospasms, what kind of medication would you give to them?
Beta 2 agonist?
Huh?
Beta 2 agonist?
Yeah, beta agonist, yeah. Adderall, Zopiness, okay? And then the next obstructive disease is bronchiectasis. Now this is the rupturing and dilation of the bronchi. Usually as a result of other conditions. For instance, there is trauma inside your airway, or maybe there is infection. Infection can cause that. You have tumor inside your airway, okay? You have cystic fibrosis inside the airway. So bronchiectasis is mainly caused as a result of other problems inside the lungs that will rupture your bronchi, your tracheobronchial tree, okay? So as a result of that, it makes it very difficult for secretions to exit the lungs. So those secretions will stay there, rather because you can't get them out. The thing is dilated and some parts of it, some parts of the tracheobronchial tree are broken. Okay, so there's no continuous flow of the secretions to the upper airway. And then they end up getting infection. And the infection makes it worse. They usually get the Pseudomonas. That can spell that. Originosa. Okay, so when they have that infection, they always cover up a green sputum. So green sputum is an indication that the patient has Pseudomonas infection, period. Okay, so on the blood exam, if they ask you, well, this patient has bronchiectasis, okay, what type of infection are they likely to get? You say Pseudomonas. They are coughing up green sputum, they may have Pseudomonas. Okay, so that's infection that patients with bronchiectasis normally get. Okay, it is a gram-negative organism. Gram-negative organism. So now, if you think about it then, because the airways are kind of like this. That's your bronchi coming out. And then here, you have damage of the airway. Okay. When you try to exhale out, okay, it doesn't go. Okay, some of it will leak out here, not all of it will make it up here and go out. So because of the damage and secretion build up, because you don't have continuous outflow of secretions to the upper airway. Okay, so you have resistance to flow coming out from your lungs. So that's what makes it obstructive disease. Okay, it's an obstruction to air coming out. And then the last one is emphysema. Emphysema. Okay. Now I must tell you that there are only 2 of them that are classified as COPD disease. Okay, so it's emphysema and chronic bronchitis. Those 2 are called COPD diseases. Okay? But all of them are obstructive disease. All of them. Okay? Now, emphysema, what causes emphysema is mainly cigarette smoking. Okay? Cigarette smoking. Now, here's the alveolus down here. So cigarette smoking can damage the alveolus. So in fact, the way we define emphysema is destruction of the airways distal to the terminal bronchioles. Now here's the terminal bronchiole. Now the terminal bronchiole is the last branch that gives rise to the alveolus. So right here, this whole thing is destroyed by cigarette smoking. Destruction of the airways distal to the terminal bronchioles. That's the way we define emphysema. So cigarette smoking can cause that. Another thing that can cause that is deficiency of an enzyme inside the lungs. That enzyme is called alpha-1 antitrypsin. Alpha-1 antitrypsin. Now, inside the lungs, down here, you have what they call a proteolytic enzyme, another proteolytic enzyme. Proteolytic enzyme. And then this proteolytic enzyme, no, it's an E here. Okay, this proteolytic enzyme normally will try to destroy the alveolus. Normally, it's just like they feed on this. Okay. So the alpha-1 antitrypsin fights this proteolytic enzyme. It fights it. It prevents it from trying to destroy this. So when you have a shortage of this enzyme, it means that this guy in here will go ahead and start picking up your alveolus. Okay? So shortage of alpha-1 antitrypsin will cause emphysema because the proteolytic enzyme that normally feeds on the alveolus, okay, will continue to do that because you don't have enough of that to fight it. Does that make sense? Okay? All right. So in terms of emphysema now, why is it obstructive? Well, if your lung compliance is how easy the lungs can open up. Okay? There's another thing called elastance. Did you go over that? So this is lung compliance. This is elastance. So you breathe in, you breathe out. So your lungs have to be able to rebound to push the air out. Okay, so compliance and the elastance are inversely related. If you have good lung compliance, it means that the rebounding effect will not be as strong. So the higher the compliance, the lower the elastance. The lower the compliance, the higher the elastance. Okay, so one of the things that will make your lungs very stiff is the number of fibers that you have. You have a lot of fibers. If you have a lot of fibers in here, down here, it means that it will be very difficult to stretch your lungs. So in emphysema, what happens then is that these fibers are destroyed, okay, by this enzyme here. The fibers are destroyed. So because the fibers are destroyed now, they are going to be very easy to open up. There's decrease in the amount of fiber. As a result of that, their lungs cannot rebound quick enough. So the air is not being pushed out. So that's how they get their own obstruction. Okay? There is decrease in the amount of elastance. They trap air. That's another way to describe it. They trap air because all the air is not being pushed out. Any questions about the 5 obstructive diseases? Okay, so some characteristics of obstructive patterns. They will have decreased decreased airflow. Okay? So if you're talking about asthma, you're going to have that bronchospasm. The air is not going to want to come out as much. If you're talking about bronchiectasis, well, the bronchi and the bronchioles are ruptured, so there is not continuous smooth coming up of the air from the lower airways. If you're talking about emphysema, well, they have decreased elastance. The air is not being pushed out. Okay, so whichever one that you're looking at, they're always going to have decreased airflow coming out from their lungs. That's characteristic of obstructive disease. They do a lot of air trapping because the flow cannot come out the way it's supposed to come out. They are retaining some air inside their lungs. Okay? They retain some air inside their lungs. They have hyperinflation. Well, if the air is not coming out the way it's supposed to come out, what do you expect? Like that, right? From breath to breath, over a period of time, it doesn't happen over one breath or so, but it's a long time, you know. They have that barrel chest. What causes the barrel chest is air trapping. Okay? Air trapping is what causes the barrel chest. Okay? Obstructive disease will have increased airway resistance, meaning that there is something blocking the air from coming out. There's something blocking the air from coming out. There's resistance to airflow. Okay? Now, it may also be normal. Now, let me tell you this now. If somebody was diagnosed with emphysema today, it started today, your lung function may be good. It will be good. Obstructive diseases are progressive in nature. They are very progressive in nature. So, diagnosed with emphysema today, I don't feel anything. But 2 months down the line, you begin to feel it. 5 months later, oh, you can breathe now. 2 years later, oh, you can't really breathe. So it's progressive in nature. So at the early stage of it, okay, they may be good in terms of breathing in and breathing out. But as time progresses, their pulmonary condition gets worse. Okay? They have increased compliance, number one, increased compliance. Okay? Now remember, in terms of emphysema, what causes increase in compliance is the destruction of the fibers. Okay? Well, if you think in terms of the other ones, what do you think will happen, you know, if you keep on putting air inside the lungs, okay, but the air is not coming out? It will keep on stretching the lungs, right? It's just like, you know, you get a rubber band, okay, and you do this to it, okay? When you start doing this to a rubber band, it's going to be a little difficult to stretch it. But if you do it over a period of time, you're going to find out that the compliance of it increases, okay? It becomes easier to stretch, okay? So that's a good analogy to think in terms of compliance. So initially, when they have obstructive disease, their compliance may be normal. But when they start doing the air trapping, or the fibers are now going away, okay, their compliance would increase. Their lungs become easier to stretch. So every COPD patient will have normal or increased lung compliance. Okay? Any questions about that? They will also have repeated infections. Do you know what actually gets out the secretions out of the lungs where the patient can cover it up? That's flow. Flow. That's how come after you finish giving a treatment to a patient, you tell them to take a deep breath and cough. When they take that deep breath, they get a lot of flow in, and then they cough. A lot of flow comes out and pushes on the secretions. So because these patients have low expiratory flow, the flow is not coming out the way it's supposed to come out. The secretions are not being pushed up the way that they're supposed to be pushed up. Therefore, you have retention of secretions inside their lungs, which would then retin there and cause infection. So normally they will have repeated infections, especially patients that have a cystic fibrosis. Okay? Our discussion of the smaller airways, we already talked about it in terms of the emphysema. Now, let's go to the restrictive pattern. Remember I told you that the restrictive pattern is here, it's compliance. Low lung compliance is restriction. Anything that can prevent your lungs from expanding is restrictive, okay? And by the way, if you don't want to go that route, just say that if any disease process, even if you haven't heard about it before, if it is not one of the CBABs, it is restricted, period. The best way to remember diseases that are restrictive is by remembering the fact that are obstructive. Okay? So if you remember CPAP, everything else is restrictive. Okay? So here we go, it says that they have stiff lungs, elastic tissue scarred, or ability to expand lungs decreased. Okay? If I think of scoliosis, you know what scoliosis is? Right there. Okay? That's restrictive because it will compress your lungs. If you think about kyphoscoliosis, that's restrictive. If you think in terms of pregnancy, well, when you're pregnant, you don't breathe very well. All that weight is on the diaphragm. Okay, that's restrictive. Pulmonary edema, that's restrictive. Pneumothorax, that's restrictive. If it is not CBAB, it is restrictive, period. Okay? So they have decreased lung compliance because their lungs cannot expand as much. Usually will have more fibers. Pulmonary fibrosis is a good example. Okay? In pulmonary fibrosis, you make a lot of fibers, which causes your lungs to be very, very, very stiff. Doesn't want to open up. Flow rates are normal. Now think about this. There's restrictions down here. They don't have anything up here. Their airway is wide open. So flow can just come out. There's no obstruction, no secretions, no nothing, no bronchospasm. So in a restrictive disease, the flow will be normal because there's nothing blocking their airway. The volume will be low because their lungs just can't expand. But in obstructive disease, we got a problem here. The flows will be low because there's something blocking the flow from coming out. Okay? So right here, the best way to remember the diseases that are restrictive is by remembering the five that are obstructive, period. If you know the CBAB, even if you haven't heard about that disease before, it will be restrictive. Examples of restrictive diseases: pulmonary fibrosis. That's a killer there. Now, in pulmonary fibrosis, the extreme stage of pulmonary fibrosis, they don't make it. if you see one of these people on the ventilator, their PIP is usually 70 because they have a lot of fibers. Okay? Usually due to inhalation of, what would I call it? Noxious gas, okay? Pollution. That's what causes that. They make more fibers, making their lungs very, very stiff. Okay? Pneumonia will be restrictive. ARDS, space occupying disorders like tumor, pleural effusion. Sarcoidosis is like inflammatory disease. Okay, the white blood cells arrive at the site to fight infection, and then they don't go back, they don't retreat back. They stay there, so you form inflammation. Okay? Obesity, pregnancy, in short, if it's not seeded, it is restrictive. Let's make it easy that way. Okay? Okay, so now, normal PFT values are based on predicted values. And predicted values are based on all of this here. So when a patient arrives in a pulmonary lab, okay, we sit them down, you turn on your computer, and then you say, well, how tall are you? The patient say, well, I'm 5'6". When you input that into the computer, how much do you weigh? The patient say, well, 160 pounds. You put that in the computer. Are you a male or female? I hope they know who they are. Because now, if you get a technician to ask somebody, are you male or female, they may just go, wow. Can't you see that I'm female, you know? So you put the gender, and then you put their age. Women don't like to tell you how old they are. You know that? If you ask a woman like me, if I say, Alexa, how old are you? Oh, well, last year what was last year? They will never tell you how old they are. Why do they do that? Why women do that? They don't like to tell your age.
We also don't like telling you our weight, so people lie.
All right, so race, they put it there. Like Dr. O would be black. But I'm not really black, I'm brown. I'm not black. Don't call me a black man. Call me a brown man, okay? Kid. And don't let me call you a white lady. Because you know what white is? Well, this is white. That's not your color. You're a yellow person. Understand? They make that mistake, though. Oh, here's a white man. And then I'm looking, well, white? Well, maybe I may be having problems with my color here. Well, that's not really white. Well, here's a black man. I'm like, well, he's not really black, he's brown. All right, so you put this information inside the computer, and then the computer goes, well, based on all of this that you put in here, this is what the patient is supposed to do. That's called predicted value. Okay? So then after that, we'll put the patient on the machine to do the actual test. And that is called the actual value, or patient value. So once we're done with that test, what we're going to do then is we are going to divide what the patient actually did on the test by what the computer said that the patient could do. That is called percentage of predicted. And then what we're saying is that if you can do 80% or more of what the computer said that you could do, then you're fine. That's the way we read it. Okay, if you can do on all of them, if you can do 80% or more of what the computer predicted, then you have normal lung function. Okay? Any questions about predicted value? It's based on height, weight, gender, age, and race. Other factors affecting normal values. Well, if you smoke, you're not going to have good lung function. Smoking is bad. Now, if you smoke now and quit smoking, you can prolong your life 10 more years, by 10 more years. Okay? I used to smoke. I told you that story before, right? I quit smoking. I'm very proud of myself. Now I can probably live and see my grandchildren, right? Yeah. All right, employment history can affect your lung function. Some people are employed in like a glass industry where they inhale pieces of glass. That's called silicosis. You can work in a mill where, where there is a lot of dust. You inhale that every day. You can work in like a lead industry, like where they make batteries for cars. They make it with lead. The lead is very bad for the lungs. You inhale that. So some of that can affect your lung function. In fact, if you work in a place like that, it is always a protocol to test your lung function every once in a while. And you gotta wear like a respirator to prevent you from inhaling all of that dust. So we check employment history is always significant in terms of trying to evaluate the cause of a patient's pulmonary problem. Pulmonary history, previous pulmonary disease, the guy cough and sputum production, dyspnea at rest, or on exhaustion, okay? PEGs, okay? Especially if you have the asthma, okay? If you have PEGs, that can, there can be triggers. Okay, there can be a trigger, if you breathe the hair in or wherever. That can exacerbate your symptoms. Place of residence. Some people don't do well depending on where they live. For instance, here in Albuquerque, the barometric pressure is about 640. Okay? At sea level, the normal barometric pressure is 760. Okay? Now, look at this. So, most COPD patients don't do well in Albuquerque because Albuquerque is actually not on sea level. Okay? Did you go over this formula? I feel like equation. Did you go over that in mechanical ventilation? Okay, so this is what's going on in terms of living here in Albuquerque. Okay? Here's your alveolus. If you calculate the partial pressure of oxygen inside the alveolus, it is approximately 100 millimeters of mercury. So in other words, this is normal barometric pressure. 47 is always there, that's water vapor pressure. FiO2 to 21%, that's the amount of oxygen in room air. Normal CO2 is 40. So if you work that, you're going to come out with 99.9999, approximately 100. So anytime you breathe in a room air, you create this amount of pressure inside your lungs. Okay, so the next thing then is inside the blood, if you're hypoxemic, for instance, let's say that your PaO2 is 60, that's what you have inside the blood. Okay. Now, diffusion is the movement of gas from area of high concentration to area of low concentration. So if I have less oxygen inside the blood, and I have more here, oxygen will want to cross over inside the blood. What we call this is concentration gradient. Concentration gradient affects diffusion. So from point A to B, if I have more here than I have here, well, gas is going to move that way. Okay? So that's how come we can have oxygen diffusing inside the blood. Because we have low level of oxygen, even if you get 90, which is normal, it's still low. Oxygen is going to want to go from here in here. But now in hypocapnia, this is 640, barometric pressure 640. So if you work this out, you have less than 100 here. Let's call it 80. It's less, it's not normal. So because the concentration gradient is lower, the drive for oxygen to go in will not be as much. Because the drive is the difference between the 2 points. Like here now, my drive here is 60. Diffusion gradient. But if I have 80 here, and then I have 60 there, my drive is only 20. The drive to go. So a lot of people don't get enough oxygen inside their blood. They have shortness of breath because they are breathing at a barometric pressure of 640. I know a family that moved here and turned around and moved somewhere else after 2 weeks because their parents just couldn't live here. Okay? Any questions about that? Family history is important, okay, when evaluating pulmonary disease because maybe somebody in your family has had cancer, cancer runs in the family, asthma runs in the family, whatever, okay? Pregnancy runs in the family. So they ask you all those questions. Yeah. All right. Let's keep on going here. Now, the next thing now is reliability and validity. If I do a PFT on Diego, for instance, and tell Brian that, his tidal volume is 500, well, how is he going to make sure that that number is correct? And that's in fact the tidal volume for him. Okay, so that's validity. How would you validate the result? Okay? So what we're saying now is that every PFT value has to be validated before we can rely on it. How do we achieve validity? Well, we have to make sure that the right equipment was used for the test. An equipment that has been approved by the American Thoracic Society or the European Respiratory Society. Those are the two agencies that approve every PFT equipment there. So if I tell Brian, well, I got this tidal volume using this parameter that is approved by American Thoracic Society, he says, okay, yeah, I agree with you. So you validate the result. Technicians' competence. Well, you have to know what you're doing. You want to tell them to blow out instead of sucking in. Okay? So if I can trust that the technician knows what he's doing, well, probably I will trust the results that the technician will give to me. Okay? Patient cooperation. Sometimes patients just don't like PFT. They don't follow command well. Ma'am, suck in and blow out as hard as you can. They don't do it well, No, don't do that. Please listen to me. I want you to suck in from your mouth and then blow out, and then you go. No, I'm not saying your nose, I say your mouth, you know. I used to do PFT, you know. But just don't follow command well. So if the patient is not cooperating with you, you cannot validate the result. It's not right.
I want you to rinse and spit. I'm not this entire glass.
Huh?
I had a patient, I gave him Symbicort, and I told him to rinse and spit. What does he do? He drinks it. It's like, cool. I looked at the nurse and I was like, I did say rinse, right? She's like, yeah.
Where was that?
Last night.
Oh dear.
I was like,
Now, the last thing is,
it's not gonna be on me.
the last thing is what they call the reproducibility or the repeatability. Now, the modernized term for it is repeatability. They used to call it reproducibility. So what that means is that basically all the PFT tests you have to do it 3 times. All of them, at least 3 times. And then you choose the best result out of the 3. Okay? Reproducibility means that the patient must produce similar results on the 3 tests. Let's say now that the first time they did it, they got 5 liters. The second time they did it, they got 1 liter. The next time they did it, they got nothing. So that's not reproducible, you know. They have to give the same effort. That's what that means. They have to give the same effort. Okay? So how do we measure that repeatability? They're able to repeat what they got before. Well, we're going to make sure that subsequent efforts will produce a result that is not more than 5% from the initial result. Subsequent effort must produce a result that is within 5% of the previous attempt. That's called reproducibility or repeatability. When they do that, then we say, yeah, we can trust that number. Okay? So I've given you an example there. So let's say that the patient did 4,000 milliliter, the very first test, okay? So you take 5% of that. 5% of that is 200 milliliter. So on a subsequent test, the patient must not get more than 4,200 or less than 3,800. If they get less than 3,800, it's not similar effort. If they get more than 4,200, it's not similar effort. Okay, so they have to be able to repeat or reproduce what they got before. And then we can validate the result. Any questions about that? So remember that 5% is usually on the board exam. All the PFT tests must come within 5% of subsequent tests. And then remember, one of them is spirometer. The spirometer is, when you're calibrating the spirometer, that's 3.5%. So don't get it confused. Okay? Let me keep on going here because we'll be done way before 3 o'clock. But I'll give you all a break. Okay, so now we're going to go into a simple spirometry, a way of measuring lung volumes. It can be done on the bedside. It can be done in the pulmonary lab. You can do it when you are getting ready to intubate your patient. Okay? So it says that performed for measurement and calculation of lung volumes. Slow vital capacity is done to measure lung volumes. Okay? Now, slow vital capacity can be done on the bedside. Okay, this is, you don't need the PFT equipment to do slow vital capacity. You can do it with a right respirometer, a pneumothocometer. When you get ready to intubate your patient, you're doing the winning parameter, you get a right respirometer, and then you hook like a mouthpiece to it, you give it to them, and then you tell them to take a deep breath all the way in and blow it all the way out slowly but completely. You are measuring the strength of their respiratory muscles. That's what you're doing. Because if their respiratory muscles are very strong, once you extubate them, they should fly. They should be okay. They should be able to maintain spontaneous breathing. Okay? So, if you want to do forced vital capacity, where you're going to instruct them and shout on them to blow out, then you're going to have to go to a PFT lab. But that's different. Low vital capacity is different from forced vital capacity. But the numbers can be the same. Okay? Okay, so the most common PFT performed can be performed at the bedside. Okay, so when you do slow vital capacity on the PFT machine, you get a tracing like that. And then that tracing is called a spirogram. The tracing that you get from doing a spirometer is called a spirogram. Now, a spirogram will tell you the different volumes inside the lungs and the capacities, how much the patient is there. Okay, so what we do is tell the patient to put their mouth on the mouthpiece, and then initially you're going to instruct them to breathe normally. Okay? So they'll go like breathe in, breathe out, breathe in, breathe out, breathe in, breathe out. And then all of a sudden you tell them, take a deep breath all the way in, all the way, keep on breathing, keep on then blow and keep on blowing slowly, slowly, and then take a deep breath. Like that. But they're doing it very slowly. And so once they do that, we get the spirogram. We can tell their tidal volume, their inspiratory reserve capacity, their residual volume, that kind of stuff. It shows up on the screen. And so that's what we're going to level right now. Okay? So right here, where they're breathing, taking normal breaths in and out, the amount of volume measured is tidal volume. How do you define tidal volume? Tidal volume is the amount of volume inspired or expired in one breath. The amount of volume. Usually what you breathe in should be approximately equal to what you breathe out. So that's why we define it that way. It's the amount of volume inspired or expired in one breath. Average tidal volume for anybody, average, 500. Just average. Okay, that's one of the long bites that we can tell. And then we have inspiratory reserve volume on top of your tidal volume. Now, if you know how to draw this, you can define all of them without even looking at your book. So this one here, I'm going to define it as additional amount of volume that I can breathe in after taking normal breath. So you go like, you're breathing way above your tidal volume. Additional amount of volume that can be inspired after inspiring your normal tidal volume. It's like your reserve. If you need to take a deeper breath, you get some more volume there to take. It's 30,000 milliliter. In fact, when we do PFT, we don't even pay attention to that. You know? Why? Because it has no PFT significance. In other words, you can't really tell whether somebody is obstructive or restrictive by looking at their inspiratory volume. It has no PFT significance. It can be normal if you're restrictive or obstructive. It can be decreased if you're restrictive or obstructive. So it doesn't really tell you anything. So we don't look at it. Okay? But it's there. That volume is there for you to breathe in if you need to breathe in some more after your normal dialing volume. Any questions about inspiratory volume? And then we have expiratory volume. So it's from here to here. Okay? Now, I can also define this by looking at the graph. Now, this is my normal exhalation here. My normal exhalation here. So I can go, well, additional amount of volume that I can exhale out after I have exhaled that normally. Okay, so it's like you breathe in, and then you go, no, then you breathe out, and then you go right there. Additional volume that you can breathe out after you have already expired out, normally. So it's 1,000. 1,000 milliliter you have, you can exhale out 1,000 milliliter additionally after breathing out your normal type of volume. And if somebody wants to hit you, they breathe out all the way so that they can get more power. Cool, knock you out. Any questions about that? Okay, so it has no PFT significance. I mean, you can't really tell whether somebody is obstructive or restrictive just by looking at, their expiratory volume. We don't really look at that. Okay, so down here is your residual volume. It is the amount of volume left in your lungs after maximal exhalation. You can't exhale out your residual volume, no matter how hard you try. Even if a car runs you over and runs on top of your chest, your residual volume is still in there. You can't exhale it out. And that is 1,500 milliliter. So these are the 4 lung volumes. This is very, very significant in terms of PFT. We can tell who is obstructive or who is restrictive. Because when you're doing air trapping, your residual volume will increase because you're retaining volume there. If you're not doing air trapping, then your residual volume will be low. Like a restrictive disease, you can't inhale enough volume in. So residual volume is increased in obstructive diseases, and it is decreased in restrictive diseases. You have to know that. If the residual volume is higher than 100%, they're doing air trapping. If it's less than 80%, then they are restricted. Okay? And now let's go to capacities. The capacity is two or more volumes added together. Two or more lung volumes added together is the capacity. And we have four of them. We have four lung volumes, and then we have four lung capacities. The first one I want to go over is vital capacity. Vital capacity. So we have vital capacity, we have functional residual capacity, we have inspiratory capacity, we have total lung capacity. VC, when you see VC, that means low vital capacity, because sometimes they don't say SVC. They can just say VC, which is the same thing as SVC. But if you see FVC, that's different. That's forced vital capacity. Okay? Now, so, it is the maximum amount of volume that a patient can exhale after taking a maximum inspiration. The maximum amount of volume that the patient can slowly exhale out after taking a maximum inspiration. So you tell them, Mr. Smith, breathe in, and they go, blow out. You go, do slowly. All the way. Okay? And then you measure that. So now, this is where they're going to take a deep breath all the way in, and then they start exhaling out. All the way, keep on exhaling, and then exhale all the way out here, and then they're breathing normal again. So in essence, vital capacity is from here to here. Because they are exhaling all the way from top down to the ULB. The maximum amount of volume that a patient can exhale out very slowly after taking a maximum inspiration. Normal is 4,500 milliliters. That's normal vital capacity. Okay? Now, in fact, there are three ways that we can express what is normal vital capacity. Okay? We can say that normal vital capacity is 4,500 milliliters, which is the same thing as 4.5 liters. We can say in mils per kg that normal vital capacity is 65 to 75 mils per kg. So basically what that means is that if you took a deep breath all the way in and blew it out completely, and then I take the amount of volume that you blew out and divide it by your body surface area, no, not body surface area, your height, okay, in kg, the number should fall between 65 to 75. Okay, so in mils per kg. Okay, and then we can say that normal vital capacity is 2 times, at least 2 times your tidal volume. Approximately 2 times your tidal volume. Now, slow vital capacity, if you want to, you can write it down. You can highlight that. You can type it up, whatever you want to do with it. But now listen to this. Slow vital capacity is the best indicator for restricted disease. Period. Because you know why? You are doing it slowly. We'll give you enough time to exhale out, but you still didn't exhale out enough time. You still didn't. So that means that you didn't inhale enough to begin with. Okay? So when your store vital capacity is less than 80% of predicted, they have restricted disease. But it can also be slightly decreased on normal in obstructive disease. I want you to make that note here. Slow vital capacity is the best indicator of restrictive disease, but it can also be normal or slightly decreased in obstructive disease. You know, COPD patients, the fear that comes from not being able to breathe in is very scary. It's very scary. Because what they do is once they breathe in, they go so that they can get another breath. Because they don't know whether they will be able to get another breath. So they are very impatient in terms of blowing out. But if you can calm them down, tell them to blow out slowly, don't rush it, you're going to find out that they will be able to get more of their air out. And then that will make the vital capacity be very close to normal, or even normal in COPD patients. But forced vital capacity is never normal in a COPD patient because of obstruction. But slow vital capacity can be normal or slightly decreased. Okay? So remember that. So when you see slow vital capacity that is low, don't really make a very, don't make decisions right away. Even though it's the best predictor of restrictive disease, just hold on, you gotta look at your flow and some more. Okay, we're gonna talk about the ratio in a few minutes, not today, maybe on Thursday, okay? Any questions about that? So now it will be decreased in a restrictive disease because their lungs are so restricted that they can't get enough volume in. Okay? It will be a normal or decrease in restrictive in obstructive disease because the patients are taking more time to blow out. Okay, they get it very close to normal. Okay? Any questions about that? Now, one thing they will do on the exam is they may say which of the following combinations of volume will equal the vital capacity. Well, here's the vital capacity here. From here to here. So if you look at it, it is the sum. Remember I told you that vital capacity was 2 or more volumes added together. Capacity was 2 or more volumes added together. Your IRV, which is from here to here, we're still down here. Your tidal volume, from here to here, and then your ERV from here to here. So the vital capacity is made up of 3 volumes. So on the exam, they say which of the following additional volumes will be equal to vital capacity. So they give you that choice, you pick it. IRV, tidal volume, ERV. You stop right. But there's another way. Okay, I can do that. Because what I'm looking at is from here to here. So I can add up my IC. IC is, inspiratory capacity is the sum of your tidal volume and your inspiratory is that volume. So from here to here, I can take that IC and then I can add it to the ERV. And then I'll get the whole thing. I'll get the whole thing from here to here. So IC plus ERV will also give you vital capacity. There's another way I can do that. Total lung capacity is the entire thing here. I can take this whole thing here, and then I can remove this from there. And then that will give me from here up. So TLC minus RV will also give me vital capacity. Now remember I told you vital capacity is 4,500. TLC is 6,000. Well, RV is 1,500. So minus that, I'm back to that 4,500, which is vital capacity. Or now if we're doing the first one, we were 3,000 plus 500, that's 3,500, plus 1,000, that's 4,500. We can do IC, this plus this, that's 3,500, plus this one here, that's 4,500. So you have to be able to add up the volumes. Any questions about vital capacity? You're going to have this on your quiz. Okay? So when you go home, start singing, okay? Sing with your lung volumes. And your parents are going to say, what? Doctor, what's wrong with you? Say, well, I'm just practicing my lung volume. Doctor, oh, why do you need to practice this? And you go, well, who is Dr. Oh? There was some guy from Nigeria. He's our instructor. All right. So let's go to the next one here. Functional residual capacity. The amount of volume left in the lungs at the end of normal exhalation. So you breathe in, you breathe out normally. So you stop right there. So right there. That's where you breathe out. So you have two volumes below that. You have your ERV and then you have your RV. So the amount of volume left inside the lungs at the end of normal exhalation is your F4C. That is the reason why people go on the ventilator. Anytime you lose your functional residual capacity, it's time to ventilate you. Because your alveoli are going to go collapse. Mechanical ventilation is all about F4C. When you don't have enough F4C, we'll give you PEEP. We use PEEP to fix F4C. How do you define PEEP? By the way, what's PEEP? P-E-E-P. Huh?
Positive and expiratory pressure?
Yeah, positive and expiratory, the amount of pressure left in the lungs at the end of normal exhalation. Guess what? A4C is the amount of volume left inside the lungs at the end of normal exhalation. They are not the same thing. Because I've seen some respiratory therapists that go, well, they are kind of the same. Well, no, they're not kind of the same. A4C is nothing like PEEP. You know, PEEP is pressure, A5C is volume. But we use PEEP to restore A4C. Now look, here is normal lung volume here, normal alveolus. Normal A4C is 2,500. But now remember, this is 1,500, this is 1,000. So if your lungs are not collapsed, you have this amount of volume here. That's your F4C. Now how about if I have athletics like that? Do you think this lung unit will contain 2,500? There's no way. That means you've lost your F4C. How are we going to fix that? What we're going to do is to give you PEEP. We'll give you PEEP, we'll blow it back up so that it can contain the volume it's supposed to contain. So we use PEEP to fix F4C. PEEP can come in different forms. They have outlets, you give them incentive parameter. That's hyperinflation. You give them IPPB. You want to blow their lungs back open. Okay? All right, so is 2,500. Now, on the exam, MPS exam, they say which of the following lung volumes, addition of lung volumes will equal the A4C? Well, let's look at it. Here's my A4C right here, from here to here. What I can do, I can take this one here, ERV, and then add it to my RV. And then I have my A4C. Or I can take my TLC, the whole thing, TLC, and then I take away the IC from it. IC is from here to here. And then that will give me this. That's the two ways that you can calculate your A4C. Are you ready for this? Functional residual capacity is increased in all the obstructive diseases. Remember, I already told you that the RV will be increased in obstructive disease, right? So, an RV will be increased because you are air-trapping. So if my RV increases, my A4C would increase. Anytime your RV increases, your A4C will also increase. Because the whole thing will be raised up. A4C is decreased in restricted disease because they can't inhale enough volume in. Their lungs are very, very, very restrictive. Okay? So, PFT interpretation, they say, well, this patient has 120% of predicted on the A4C. You go air trapping. Obstructive. That's a giveaway. Okay? All the volumes and capacities are increased in obstructive diseases. All the volumes and capacities are decreased in restrictive diseases. Period. All the flows are decreased in obstructive diseases, and all the flows are normal in restrictive diseases. If you can remember these four things, that's it. Let me say it again. All the volumes and capacities, standard volume, inspiratory reservoir, all of them, okay, are increased in obstructive diseases. But they are decreased in restrictive diseases. Now, if I'm interpreting PFT, you go, well, A4C is 60% of predicted, I just say restrictive. Because what we need is 80% to 100%, that's normal. Above that, you are doing air trapping. Above 100%, you are doing air trapping. Below 80%, you are not inhaling enough volume in. Okay? And then all the flows are decreased in obstructive diseases. And they are normal in restrictive diseases. You need a break, or you want me to finish up?
You can finish.
Huh?
You can finish.
Okay. So inspiratory capacity is maximum amount of air that can be inspired after a normal expiration. You breathe out, normally, and then that's what patients do when we do incentive spirometer. So IC is incentive spirometer. When you tell your patient to do incentive spirometer, they're doing IC, they're taking deep breaths. Okay, deep breaths. Normal is 3,500 because then that would be this plus this. This is 3,000, and the other one is 500, so it's 3,500. So what's normal IC, incentive spirometer, like? If you get that incentive spirometer and look at it, it goes up to 4,000 milliliters. Sometimes some of them will go to like 3,500. Okay? Have you ever had a patient that actually sucked nothing out through the bottom? It's hard to see, you know? And if they suck it up 3,500, sometimes they don't do it well. You know that they're going like that. If you get a patient doing it that way, you say, no, so that's not it. Take it slow, deep breath, and see if you can get the float on top. You're not supposed to do it very fast. All right. So on the exam, they can say, well, which of the following addition of volumes will result in IC? Well, I can take my third volume here, right here, and then I add it up to my IRV. That will give me my IC. Third volume 500, inspiratory reserve volume 3,000. You add it up, you get 3,500. Or, here's my A4C right here. From here to here, well, what I'm looking for is from here to here. So how about if I took the whole thing here and removed this from it? So TLC minus A4C will give me this. Any questions about that? Now, TLC is easy. The maximum amount of volume left in your lungs after you have taken a maximum inspiration. So you breathe in all the air inside your lungs, 6,000 milliliter. 6,000 milliliter. Okay? TLC, because you know it's the whole thing here, so it's a part of the residual volume. So if my residual volume goes up because I'm air trapping, the whole thing goes up. So TLC is increased in obstructive disease, and it is decreased in restrictive disease. If my RV goes up, TLC goes up. If my RV goes down, TLC goes down. Okay? Now here's the TLC here. I can add A4C from here to here, add it from here to here. So that's my IC plus my A4C. That can give me the whole thing. That's total lung capacity. So now, from here to here is 3,500. From here to down here is 2,500. 3,500 plus 2,500 equals 6,000 milliliter. That's your TLC. Or, another way I can add it up, I can add up the entire volume. I can add IRV, tidal volume, inspiratory reserve volume, RV. Addition of those four lung volumes will be the TLC. There's still another way I can use that. I can take my vital capacity, which is from here all the way down here, and then add this one here to it. So vital capacity plus your RV will give you a total lung capacity. And again, you're going to have that on your quiz. Any questions about how to obtain capacities and lung volumes? Now here's this one here. This is RV divided by your TLC. Okay? What is left inside the lungs after maximum exhalation divided by all the volume inside your lungs when you take a deep breath. Okay? Now, if I'm doing air trapping, if I have COPD, right? It means that I will be retaining some volume inside my lungs. My RV will be higher, right? Let's say my RV is 25. That's just an example. Okay? Now, my TLC is 100 right now. Okay? But now, I'm doing air trapping. So the RV goes up because I'm trapping air. Let's say it goes to 50. Okay? 100. That's 50% there. Is that right? Yeah, that's right. Okay, so, but now, if I'm not doing air trapping, this number goes down so that when I divide by 100, I get the lower number. Okay? So, in this here, when you're doing air trapping, the number will be higher because you have more volume. If you're doing, if you're not doing air trapping, the number goes down. But the normal is 20 to 35%. So if it's greater than 35%, you have obstructive disease. Okay, if it's well lower, you have restrictive disease. Okay, sometimes it can actually be good normal in a restrictive disease. Okay, so if they say that the RV over TLC is high, then you get obstructive disease. Okay? Because then actually this will be over 100% of predicted. It will go over 100% of predicted, like 120. Okay? Any questions about that? You know what mini volume is? Diego, what's mini volume? How do you define mini volume?
It's the amount of volume you breathe in 1 minute.
Yeah, bingo. Yeah, that's it. The amount of volume inspired or expired in 1 minute. So you should know that. Sometimes they may do that in the pulmonary lab. Brian, what's respiratory rate? How would you define respiratory rate?
How many times you breathe?
In 1 minute, right? Yeah. How many times you breathe in 1 minute? Normal is 12 to 20. Now, if somebody has a restrictive disease, do you think that their respiratory rate will go up or go down? Yeah, it will go up, right? Yeah, so if you're breathing very fast, then we say, well, you know, the reason you're breathing fast is that you're not getting enough volume in. That's why your respiratory rate is going up. But if your lung compliance is good, each time you breathe, you get more volume, then your respiratory rate will be on the low end. Okay, so if you're restrictive, your respiratory rate goes up. If you're obstructive, your respiratory will tend to go down because you have normal lung compliance, normal or increased lung compliance. Values not measured with simple spirometry. Any PFT value that has RV in it plus the RV itself cannot be measured with a simple spirometry. There's a special test that you can use. Okay? Like blowout, no, we don't measure that. So if you want to measure your residual volume, you're going to have to use the body box, body plethysmograph. That's what you're going to use. You can do with simple spirometer. If you want to measure your F4C, you're going to do one of these three tests. You can also do body box. You can do the helium dilution test, or you can do the nitrogen washout test. So on the exam, they may say, which of the following PFT values cannot be measured by simple spirometry? So it will be RV. Best way to remember that is the RV, or any other value that has RV attached to it. Now, the F4C is the addition of your ERV plus your RV. So you can measure that with simple spirometer. Okay? TLC, your RV is a portion of your TLC, so you can measure that with simple spirometer. You don't need another test to measure this three here. And basically, your body box will measure all those three. Okay? Any questions? So this is the fundamentals of PFT. You gotta remember this, and then as we go along, you will get everything else, okay? So volumes and capacities increase in all the obstructive diseases. They are decreased in all the restrictive diseases. Flows are decreased in all the obstructive diseases and normal in all the restrictive diseases. Okay? All right, so that's it. Then on Thursday, we're going to have our quiz, and then we're going to go into forced vital capacity. Okay? All right. See, I told you that today's lecture will be very brief. Yeah, I don't like to keep people 4 hours on it.